Welcome back to IGGC monthly IGGC conversations. The editor's choice. Today, we are diving into some recent papers in gynecologic oncology. I'm Christian Braun.
I'm Julia Gellison.
And I'm Kyra Fischer.
As early career investigators, it's crucial for us to stay on the top of the latest research. Today, we are discussing three interesting articles that touch on molecular testing, targeted therapies, and surgical staging in endometrial and ovarian cancers.
Absolutely. These papers offer some really valuable insights into how we can potentially improve patient outcomes, whether through more precise treatments or optimized surgical techniques.
And importantly, they represent real-world data and large cohorts, which helps bridge the gap between clinical trials and everyday practice.
Great point. Let's jump right in with our first paper, Genomic Alterations, Molecularly Targeted Therapies and Survival, a real-world endometrial cancer molecularly targeted therapy consortium cohort study by Angeles Alvarez Zicord from the Duke University, USA. This paper looked at advanced and recurrent endometrial cancer and the impact of tumor testing to direct therapy.
Right. The objective was twofold: confirm the proportion of patients with at least one actionable alteration and determine if molecularly targeted therapy was associated with improved survival. They formed a multidisciplinary consortium, the ECMT² consortium, which gathered real-world data from 12 centers for this study, though the consortium later grew to over 20 sites. They included 967 patients with advanced or recurrent disease.
They also perform various types of tumor testing, including next-generation sequencing, immune histochemistry, PCR, and FISH, based on the physician's discretion. They were specifically looking at alterations in 11 pre-specified genes, plus other markers like mismatch repair, p53, and hormone receptors.
What were the key findings regarding genomic alterations?
Well, they found that a very high proportion of patients had targetable alterations. Specifically, 94% of patients who underwent next-generation sequencing testing had at least one genomic alteration in the 11 pre-specified genes. The most frequent alterations were in PI3 kinase with 35.8% of patients, TP53 with 34.7% of patients, and PTEN mutations for 26.5% of patients.
It was also interesting to see the differences in genomic alterations based on race. Black patients were more likely to have TP53 alterations, almost 43% compared to 31%, and also abnormal p53 staining, which was almost 35% versus 23%, while white patients were more likely to have PI3K, PTEN, and tumor burden high cancers, as well as MSI high and DMMR cancers. This highlights the importance of studying diverse populations, as this consortium did.
Absolutely. And on the survival front, which was the other main objective, they looked at a subset of 233 patients who received 292 matched biologic therapies.
And what did they find about survival of two patients?
The results were promising. They found favorable survival outcomes for those receiving matched biologic therapies compared to historical data for those treated with chemotherapy. The median progression-free survival for the matched cohort was 6.9 months, and the median overall survival was 20.5 months. This compares favorably to typical chemotherapy regimens. They cite literature showing survival outcomes for patients receiving conventional chemotherapy with median progression-free survivals between 3.8 and 4.7 months, and median overall survivals between 10.8 and 12.3 months.
They also stratified the matched therapies into non-immunotherapy and immunotherapy regimens. While median PFS and OS were somewhat similar, immunotherapy regimens showed significantly higher 1 and 3-year progression-free survival rates compared to the non-immunotherapy regimens. So 1 year 42 versus 33%, and 3 year 32 versus 14%. This suggests that the immunotherapy-based regimens might be preferred when biomarkers match.
So the takeaway here is that genomic testing for advanced and recurrent endometrial cancer is feasible in the real world and can help direct therapies that are associated with improved survival outcome. It also highlights the need to address challenges like cost, equitable access, and inconsistency in testing platforms.
Exactly. It strongly supports the use of genomic testing to direct molecularly targeted therapy and informs future clinical trial design.
Okay, that was a really comprehensive look at how molecular testing is impacting endometrial cancer treatment. Let's move on to our second paper, the Sentinel-Seneca study, risk factors for unsuccessful bilateral sentinel lymph node mapping in endometrial cancer by Felix Boria from the University Hospital Nuestra Señora de la Candelaria Santa Cruz de Tenerife, Spain. This one focuses on the sentinel lymph node biopsy in endometrial cancer and factors associated with mapping failure.
Yes, this was a massive retrospective multi-center study involving over 2,000 patients with clinical stage 1 to 2 endometrial cancer from a total of 64 centers in 17 countries. Their main goal was, as Christian said, to identify risk factors for unsuccessful bilateral sentinel lymph node mapping.
They had high overall sentinel lymph node detection rates, 97.3% for unilateral mapping and 82.7% for bilateral detection. The study analyzed various factors that might influence the success of mapping.
And what the multivariate analysis reveal as the key risk factors to failure to map bilaterally?
They identified 5 significant factors: high-grade histology, myometrial invasion over 50%, low volume surgeon, which was defined as performing less than 20 cases per year, an open surgical approach, and using a non-indocyanine green tracer.
That non-ICG tracer factor was particularly striking, showing a nearly 5-fold higher likelihood of failure compared to ICG. It is important to keep in mind that the large majority of cases in this study, greater than 96%, used ICG dye alone or in combination as their tracer. So these data are based on small numbers of non-ICG cases. However, these data reinforce the growing consensus around ICG being the preferred tracer for sentinel lymph node mapping.
And the finding about surgeon volume is important. It supports the idea that experience plays a crucial role in the success of technique.
Yes, exactly. The study authors emphasize that efforts should be made to perform sentinel node biopsy with ICG through minimally invasive surgery and by, or at least under the supervision of an experienced surgeon, which is defined by a greater 20 cases per year. And wait a second, they also checked if young training faculties impact the detection rate.
They did, Kyra, and they found that tracer injection by a resident or fellow was not associated with lower sentinel lymph node detection rates. They also looked at the impact of adding traditional lymphadenectomy to sentinel lymph node biopsy. Unsurprisingly, adding bilateral pelvic and/or periaortic lymphadenectomy significantly increased both intraoperative and postoperative complication rates. Intraoperative complication rates increased from 2% to 8.4%, and postoperative complication rates increased from 4.1% to 11.2% with full lymphadenectomy. This reinforces why sentinel lymph node biopsy is preferred. It's associated with less morbidity while providing accurate staging information.
So, right. So the Seneca study provides strong evidence on how to optimize the sentinel lymph node mapping technique in endometrial cancer by focusing on tracer's choice, surgical approach, and surgeon experience.
Exactly. It helps refine our approach to surgical staging, which is critical for an appropriate treatment planning.
Fantastic. Now, for our third and final paper, we are shifting gears slightly to ovarian cancer. Role of lymphadenectomy for apparent early stage low-grade serous ovarian carcinoma by Elizabeth Tabridi et al. From the University of Pennsylvania Division of Gynecologic Oncology, Philadelphia, Pennsylvania, USA. This study investigates the incidence of lymph node metastasis and the impact of lymphadenectomy in the specific subtype.
Low-grade serous ovarian carcinoma is a rare subtype, and the role of lymphadenectomy in apparent early-stage disease isn't fully clear. The study used data from the National Cancer Database, including 977 patients diagnosed between 2004 and 2015.
They found that the rate of lymphadenectomy was 66% in this cohort. Importantly, the overall incidence of lymph node metastasis was 7.5%, and the incidence was higher in patients with apparent stage 1C disease, meaning 10%, compared to stage 1A, which was 5.6%.
So lymph node metastasis is not a rare event in apparent early stage low-grade serous ovarian cancer, especially in stage 1C. What about the impact of lymphadenectomy on the survival?
That was another key finding. Patients who underwent lymphadenectomy had better overall survival. The 5-year overall survival rates were 91.6% for those with lymphadenectomy compared to 83.3% for those without. The survival benefit remains statistically significant even after controlling for confounders like age, race, comorbidities, stage, and receipt of chemotherapy.
The authors suggest the survival benefit is likely due to stage migration and the ability to tailor adjuvant treatment based on accurate staging. Finding positive nodes upstages the patient, guiding recommendations for adjuvant chemotherapy.
Yes, this makes sense. If you don't perform the lymphadenectomy, you might miss nodal disease, potentially undertreat those patients.
Exactly. While some studies have reported increased morbidity with lymphadenectomy, this particular study found comparable rates of unplanned readmission, prolonged hospital stay, and 90-day mortality between patients who did and did not undergo the procedure. However, it's worth noting the study's limitations, including its retrospective nature and the lack of granular data on specific surgical details and complications.
Of course, but nevertheless, the conclusion is clear. Lymphadenectomy should not be omitted when staging patients with apparent early-stage low-grade serous ovarian cancer, given the non-negligible incidence of nodal metastasis and the implications for adjuvant treatment planning.
Great. And these 3 papers really provide a snapshot of how we are using molecular information, refining surgical techniques to improve care of patients with gynecologic cancers. The first highlights the promising of target therapies in endometrial cancer based on comprehensive genomic testing. The second optimized the critical sentinel lymph node technique in endometrial cancer. And the third clarifies the importance of lymphadenectomy of accurate staging in low-grade serous ovarian cancer.
They all underscore the importance of precise, individualized approaches to both diagnosis and treatment.
And of course, the value of large real-world data studies in complementing prospective clinical trials.
Well said. Thank you both for this insightful discussion, and thank you to our listeners for joining us for the IJGC conversation, the May Editor's Choice. We will be back soon with more discussion on the latest research. Goodbye.
Thanks for joining us.
We'll be back with more updates from IJGC. Bye.